Welcome, everybody. This is the first quarter meeting of the Multi-State Collaborative. We started with this collaborative a year ago, and this particular meeting, we are fortunate in that the topic that we are covering is how to use Medicaid expansion dollars to cover school-based mental health services. Now, as you saw, as you entered, we are recording this meeting, and we do make it available after the meeting, not only for your reference, but for those individuals who were not able to join us today. So I am going to ask each of you to please put in the chat. This is a collaborative, so we want you to get to know each other. Put in your name and affiliation and state. As I said earlier, we have 10 states represented today, and I'm going to take a quick break because my screen sharing is not working. So if you just bear with me one moment, I'm going to fix that. My apologies. For some reason, it is not identifying or me as the host, even though it's listing that way. So I will keep working on that. And I'll just talk through this in terms of the multi-state collaborative. The purpose of this group is to enable those who are working to prevent, treat, and solve youth behavioral and mental health issues to collectively share best practices across states. A variety of goals are coming with the collaborative. So as I said, we're going to share best practices in a range of areas. We already have since last year in terms of referral and screening and assessments, safety planning and care management, billing and reporting. Now, the common thread, but not necessarily everyone, but the common thread among us is that you're using BHWorks, the software platform, as the integrated technology infrastructure. We also discuss state-specific behavioral health learning collaboratives, that means Pennsylvania and Michigan, that share validated trainings and shared methodologies. We also share resources for grants and other funding opportunities. We also share national policy and leading evidence-based trainings. One thing I wanted to show is with respect to state Medicaid expansion dollars. As you know, each state varies in where they are with respect to that expansion, whether they have already done so. And today we're going to hear from Michigan, which is obviously has expanded Medicaid coverage in schools. There are some states, about 5, who are in the process of expanding. And then there's unfortunately quite a number that have not yet taken action. Doesn't mean that they won't, but it's something for the states that have not yet expanded to hopefully advocate and work towards. Now we are fortunate to have two experts. So today the topic is using Medicaid expansion funds to improve student mental health outcomes. And if you follow Michigan's model on how to accomplish this within your state Health and Human Services Department and your Department of Education, you can increase provider reimbursement and participation and use our software technology to increase efficiency and generate outcomes data. Our speakers today, we are fortunate to have Dr. Kevin Bauer, who is Medicaid School Services Policy Specialist within Michigan's Department of Health and Human Services. He is well known in the state as well as across the country. One of my tips is if your state has not yet expanded Medicaid, you need to find your Kevin Bauer, and he probably knows who that is in your state. Our other speaker is Scott Hutchins, and he is our school mental health and Medicaid consultant for the Michigan Department of Education. He is a modest leader. I'd say since he was in this position for the last few years, he and Kevin and all the providers in Michigan have secured coverage for thousands of students and have improved the services that are being delivered to them. I'm going to apologize as I try to work on the slide deck. I know Kevin and Scott know this very well. So I'm going to work on the slide deck and hand it over to you two. And thank you for being here.
Thanks, Marjorie.
Thank you.
Kevin, let me start by just asking, do you have access to the slides? I do, but I don't know if you do or not.
I do not.
Okay, that's what I thought. So I didn't want to get too far ahead without. So yeah, forgive us on the back of all this. I'm going to send the slide deck to Kevin. So welcome everybody. It's a pleasure to be here. My name is Scott Hutchins, as Marjorie said, School Mental Health Medicaid Consultant, Department of Education. In addition to all the other fun things that are taking place with this technology challenge, I do not have power in my house. So luckily my wife works at Consumers. So I was able to steal a area and get some power and some heat to present to you guys. But yeah, we're definitely ad-libbing this afternoon. I also, in addition to having power, was down for the count with COVID last week. So I'm just gonna apologize up front. COVID brain is real. If you have not had the displeasure of testing positive for COVID and being knocked on your can like I was for 5 days, it takes some getting used to, and it takes some time to recover. So all of that to say, here we are. I'm excited to be here, but just bear with us with not just the technology issues that we're having, but with everything else that's taking place. So, but as Marjorie said, the goal of Kevin and I's presentation today is to, for those of you that are not already expanding your Medicaid programs, to just kind of give you some highlights about how we, or what we're doing in Michigan. We have some amazing partners on the call today, and I want to acknowledge them. I'm very grateful to see so many folks from Michigan. The truth of the matter is, Kevin and I talk about this all the time. The success of Michigan's program is truly the folks that are in the field that are coordinating these services, hiring the direct service providers that are meeting students' needs and working with them. So it's an honor that Kevin and I get a lot of the credit sometimes, but the true heroes are, like I said, those of you that are on this call from Michigan, that are in the field, getting services to students, coordinating services for your providers, and providing that care that your adults need as well, right? I mean, that's one thing that's so critical is you've got adults that are working with students with high needs, but those adults also themselves, are carrying a lot of responsibility. So again, I don't want to go any further without just stopping for a moment to thank them and show the appreciation that they deserve and thank them for being here. So with that intro, Kevin, let's check. Did you get the slide deck and are you feeling comfortable on the back end?
Oh yeah, I've got it. I'm up and running. And you know, when we've talked about this program so much, it's really easy to feel comfortable with it. And it's easy to talk about because it's something we truly believe in. And quite honestly, it's made a world of difference for our kids. And we just are happy to be where we are right now with the program. So basically what happened is in December of 2014, we got the Dear State Medicaid director that now said that they are rescinding the previous free care rule that said you couldn't bill for services to Medicaid if you didn't bill them to other, to everybody basically. So we looked at that and we thought, you know, there's got to be a way that we can kind of make this work for us to start providing services to our students that are not falling under special ed. And so we looked at it and it really came down to whether we were going to be able to have a separate line item, because we're a cost-based reimbursement state, a separate line item for two different Medicaid eligibility rates, because your special ed eligibility rate tends to be much higher than that of with students without an IEP or IFSP. So we looked at it, and without doing anything else, any additions to our program for providers or services or anything, if they allowed us to have a separate line item without doing anything else, we would have a $3 million profit. However, if they required us to average out those two different Medicaid eligibility rates, we would lose about $31 million a year. So we really had to take a look at which way CMS was going to allow us to go before we went, because there was absolutely no chance that we were going to take a chance on $3 million and lose $31 million. At that point, I'm going to be known as the worst finance guy in the world. So we weren't going to let that happen. Well, we found out eventually when Massachusetts started moving forward with their state plan amendment that CMS was going to give us a separate line item for that Medicaid eligibility rate. And at that point, we started moving forward. Well, a fire got lit on us under us in December of 2018 when our lame duck legislature was leaving town. And the very last bill I think they enacted was that they said that they were going to require us to open our state plan within the next 10 days and put in to expand our program. And they were going to offer us some money to help out with that. We got that in before the end of the year. And then in August of 2019, CMS approved our state plan amendment, authorizing us to go the route of free care, or as we called it, our C4S program. And we went operational on the 1st of October. That was a very aggressive timeline to go from nothing to 10 months later being fully active. And that is a credit to our implementers out in the field, our ISDs, our LEAs, and everybody else. And what we did was our bulletin that we put out is MSA 1926, and that outlines a lot of things. For one, we expanded our provider base. We started thinking a little bit outside of the box because we knew that we were going to run into a problem with a shortage of providers. So one thing we did was we looked at marriage and family therapist and realized their credentials mirror that of the licensed master social workers. So we brought them into the schools. We also were able to start getting direct service reimbursement for our school psychs. And we also added our behavioral board certified behavioral analyst to the equation at that time. And this had the effect of increasing our number of students that we covered from 108,000 special ed students to 980,000 students overall. Not to say that we have 980,000 students receiving services, but that's how many we currently cover within the schools that are eligible for services. Anything to add, Scott?
No, actually, I was just gonna kind of tee you up with a question. If you could talk about Michigan with us being a cost-based reimbursement instead of a fee for service and what that looks like.
Yeah, for those of you who aren't familiar with the way Medicaid pays out, you have a couple of common systems, and one is fee for service, or as I call it, bill this, you get that. So in other words, you bill a code for the therapy that's provided, and you get paid a set fee for providing that service. Under cost-based, what you do is you take the cost of providing service, which is primarily the salaries of the clinicians, and then you have a number of factors that you figure in, such as a random moment time study to determine a percentage of their salary where it's actually being spent providing Medicaid or medically eligible services. Sorry, misspoke there. Then you apply the Medicaid eligibility rate, because you've got to take that percentage of medically eligible services and break it down to what percent was provided to Medicaid eligible individuals. And the reason for that is, while you're providing services to every student, we can only bill Medicaid or be reimbursed by Medicaid for those services that are provided to Medicaid eligible students. So that's the biggest difference.
And one of the key things that, in addition to the Medicaid expansion that Kevin's talking about, that Michigan was able to do at the same time. So in parallel, we had the Medicaid expansion, but we also had a significant investment from the legislators in our State School Aid Act. And it was those two things that occurred hand in hand that really made the difference. So when Marjorie kind of started talking about, other states that are looking at expanding their Medicaid plans, or those that are currently doing it, again, one of the reasons that Michigan was so successful was because we had the legislators looking at an additional amount of funding to kind of get things going, but they really wanted to create a sustainable model. And so that's when they reached out to, Department of Public and Human Services, Kevin's team, and others about how can we make this a sustainable program, because we want to add services in the schools, but what we don't want to do is turn around and have to, lay people off or not be able to continue to employ them because of funding. So that's why we looked at that Medicaid expansion and why it was such a critical component. So we actually started with a very small amount of funding in fiscal year 2018-19, roughly $20 per student in the state of Michigan, or approximately $30 million. Now, keep in mind, again, this was prior to the pandemic. This was prior to an extremely unfortunate incident that took place in Oxford, Michigan, in November of 2021. Obviously, again, the legislators and the other people that came together had the forethought that we need to do something for our students. We were looking at, historically across the country, there was a lot of violence that was taking place in schools. So they were looking at, again, why are students hurting themselves and hurting each other? And instead of investing in the hardening of schools, again, they chose to invest in bringing behavioral health providers into the schools to provide services. And then again, right in conjunction with that was that expansion of Medicaid, which was so critical. Again, fast forward from the end of 2018-19 fiscal year to where we are now. We've since also, gone through a pandemic. As I mentioned, we had that terrible incident in Oxford. Fortunately, we had another one earlier this month at Michigan State University. So we know the needs are continuing to be there, and the legislators are going to continue to support providing these mental health services. But again, without that Medicaid expansion component right along with that, budgets change all the time, right? Especially state budgets, and even our family budgets, right? My children are a senior in high school and a sophomore in college. My budget's changed quite a bit the last couple of years. So I was looking forward to them getting out of the house, not forgetting the fact that, oh yeah, college bills and everything else. So again, state budgets change just like our own personal budgets do. Governor Whitmer, for example, here in Michigan, ran a platform on fixing the damn roads, right? She wants to deliver on that promise. The money's got to come from somewhere. So again, important piece of the budget, that hand in hand compatibility with that Medicaid expansion was so critical. As I mentioned before, we've seen a significant increase because of the pandemic and because of those other things. I mentioned we started with around $30 million in recurring funds. That actually this year went all the way up to $78.9 million in recurring funds, plus an additional $282.5 million in one-time non-recurring funds. So that's collectively almost a $350+ million investment from our legislators and from our governor's office, just in mental health funding in the State School Aid Act.
Scott, let me jump in here real quick.
Please
And
do.
I want to point out the importance of having that funding, because one thing that there's a common misconception is that Medicaid will fully support your program. And as I was pointing out, Medicaid's not going to fully cover the cost of running this program, because you have those various step downs. You have the step down from the random moment time study, because they're decreasing it to the percentage of time that that salary person is being used to provide medically qualified services. There's a further step down because they have to decrease that to the percentage of Medicaid eligible students that services are being provided to. And then finally, you have the step down when you figure in the federal match assistance percentage to figure out what share of that is the federal share. So there's quite a step down on this. So it's always important to have outside funding in the form of grants or wherever you can get money. And, you know, that's why it's so important that our legislature has helped out and kicked in what I consider to be substantial amounts of money to ensure the success and that behavioral health in our schools is addressed.
First of all, I'm going to apologize not only to our speakers, but to the participants with respect to the slide deck. I will ensure that it gets to each of you post meeting. Zoom, the admin is locked and I can't, it's not recognizing me as host. But I want to pose some of the questions that are in the chat, if you don't mind. So Jen Lords, who is with the Nevada Department of Education, is asking, how are your school psychologists credentialed to bill for Medicaid? And what designation do they bill under? For example, do they have to work under the direction of a mental health clinician, or are they considered a mental health clinician?
Well, I'm going to say that this seems to be getting a different answer depending on what area of CMS you talk to, what region you talk to, and what day you ask them. We were very fortunate in that at first they said, go to your attorney generals and have them say that the degree of the school psych is equivalent to a PhD psych. And obviously our AG said, no, a master's plus is not the equivalent of a PhD. And I went, well, yeah, I was hoping you'd say different, but I've seen that one coming. And so I asked CMS about it, and they came back with, well, under EPSDT, you can claim it as a habilitative or rehabilitative person. No other credentials needed. Now, other states have not had that success. Colorado went through a fully different way to get their school psychs reimbursed, but I believe Colorado also does not need to be supervised to have those reimbursed. I know we in Michigan do not, but I can't speak to all the steps that they have taken in Colorado. It would Shannon Huska would be a good one to reach out to for that. But like I said, the experience depends greatly, it seems like, on who you ask at CMS and when you ask them. So a lot of different answers for different states.
Yeah, and I'm seeing Mark Smith, who is with the Ohio Department of Education. I know, Kevin, you know Mark. So he responded to Jen. So Jen did then ask, do they have dual licensure with your state board of examiners for psychology? No,
they do not. They do not have, and yes, Mark Smith is a good friend, and I'm very fortunate to have him as a friend.
Mm-hmm. So for those of you in the chat, you'll see Mark's response about Ohio. And Kate is in Alaska, and she's asking, are the expanded provider types in your schools employed by the school or the community provider?
Oh, that is a great question. First of all, when we expanded all of our services. We didn't, say it was just going to be psych. We just kind of went across the board to pick up nursing and anything else we could. We knew we weren't going to get a lot of OTPT, actually almost zero, but we expect to get a few speech and more nursing, but mainly our psych services and behavioral health services. And what we have in Michigan is they being our schools have an option of employing the clinicians themselves, and claim them on the cost report, or else they can contract with an outside entity to provide those providers to the school, put them on the random moment time study, and then they can claim the cost of their contract on their cost report for reimbursement. And the third option would be to allow the provider to come into the school at no cost to the school, provide services, and then they bill through their fiduciary entity. And when they do that, they fall outside of our program. But the first two options, you can either be employed by the school or contracted to come into the school. And then they fall under our school services program for reimbursement.
Kevin, can you cover the piece about how the ISDs are still the ones that are billing Medicaid under their MBI, regardless of which model they go with?
Yeah, under the first two models, it is the ISD that is doing the billing. The clinician, whether they're contracted or an employee, actually bill through the ISD. We do not have individual MPI numbers in Michigan at this time for our school services clinicians. So they bill under the MPI number of our ISDs. And ISDs, for those that aren't familiar with the way Michigan does things, think of it as a super LEA that has LEAs underneath of it. It's kind of like a regional or county entity that for administrative purposes.
And this is again from Kate in Alaska. Are school counselors able to capture reimbursement for anything in the Michigan state plan?
That is a touchy thing, and I'll explain why. There's some concerns with school counselors, especially in a cost-based system. For one, we do reimburse for licensed professional counselors. But the thing about school counselors is they do so much other than provide medically qualified services that with a random moment time study, you could actually see a real depletion of your percentages if they are brought in. So it could be one of those cases where you're chasing a penny but losing $1. So that's one of those things that you really have to be careful of. If you're going to bring in the school counselors, you have to look at what the effect will be on your program first. It could actually be in that you end up reimbursing for more clinicians, but are receiving less money because of that percentage that we're talking about.
And I see Tom Delaney in he's with the Minnesota Department of Education, posted that school psychs are covered only if they have state psychiatric board licensure as well, which is only possible at the PhD level for school psychs.
For that, that's Minnesota's, Tom?
That's Minnesota. Yeah.
We were pretty fortunate in that CMS really opened it up for us. And so I know that other places had been less fortunate in that.
Yeah. And Tanya, hi Tanya Hernandez from Nevada. Can the difference in the school psych with the SPAs be an issue of IGT versus CPE?
It may be. I haven't really given that much thought, but yeah, that could be, but you still have to be able to claim them. And like I said, CMS was very, very lenient in saying, well, basically you can claim whoever you want to under the provisions of EPSDT, which is the parent program for our school services program.
It seems states that allow for the billing are all CPE states, as Tanya responded. I'm going to go back to, and Tara Allen, is Montcalm, are you in Michigan, I'm assuming?
Yep.
Yes.
Yes. Okay. So Tara had responded back to Kate in Alaska, just if you haven't, for Michigan, it depends on the district. She's a community partner with a local intermediate school district, and the money comes to the intermediate school district, and they contract with Tara's network, and they provide the services to the local districts. And some of the school districts employ staff directly, and others give the money to the locals to employ staff. to help answer that. And then Kate is another follow-up question in Alaska. For cost-based reimbursement, does it include a fully benefited position or just their annual salary?
Yeah, what we do is we do have our it's salaries and benefits, so you can claim the benefits as part of the reimbursement process as well. So, and that is for, you don't have to have a full-time person, you can have anybody that's part-time. One of the things that we do have some checks in our system is to check for a percentage of benefits to salary ratio, though. It's kind of a believability check that would trigger it automatically, and then we have an override process if indeed that's correct. But yeah, we actually do have positions in Michigan where our benefits do exceed the salary of the individual that we're able to claim.
So Tanya would like to poll the audience, and she's asking, are any of you IGT states that the Centers for Medicare and Medicaid Services has approved your state SPA for school psych to bill for their services? You can put it in the chat, raise your hand. Anybody? It doesn't look like that, Tanya.
I think we might have found the common denominator here. Interesting.
That is interesting, because I've never really looked at it, because quite honestly, once we got approval, I kind of gave up at that point and went, okay, we're good. One thing I will put out there as a cautionary tale with school psychs is, one thing that we found in Michigan is we picked up a lot of salary on those individuals. However, the offset of that was we seen a drastic drop in our random moment time study percentages, because much of what a school psych does not mesh well with a random moment time study moment. The other thing that we get into a lot with our behavioral health professionals, and you do this with any time you add new people to the thing, is they look at it and go, okay, we're following a school plan of care, so everything we do is educational. And you're like, no, don't go down that route, because you're gonna kill us with that. You know, we've got to kind of make a point of pointing out. And one thing we do is we have quarterly meetings with our ISDs, so that we can train things like that out. We also have a summer conference where we do a lot of heavy hitting with things like that and try to make sure that everybody's on the same page. So really looking forward to getting back in person this year, so that we can start working on that and hopefully see our RMTSs come up a little bit. I don't think they'll ever return to where we were, just because the school psychs have taken a little bit of hit on that random moment time study, which is exactly what I was talking about with the school counselors we were talking about. The fear is so little of their random moment time study would be able to be a positive moment that you could actually drop your reimbursement down by adding more people, if that makes sense.
That's always interesting. Kate put in the chat, she's from Alaska. She says Alaska does allow reimbursement for psych evaluations, but she's not sure if that fits your question.
Yeah, it does, but kind of in the random moment time study, things get sorted out a little bit differently, and sometimes it misses that. You know, so yeah, we did take quite a hit. So we're training on that right now, trying to get those numbers back up a little bit.
And Tanya is asking Kate, do you see that in the chat? Is Alaska IGT or is it CPE?
I don't know
Okay.
what IGT is.
IGT would be your intergovernmental transfer, and that is when you're talking more about the fee-for-service states versus the cost-based.
We are that. We are a fee-for-service state, at least under our school-based plan.
And what do your school psychs bill for, Kate?
They're eligible to bill for evaluations and some what's titled as behavioral health services, but it's actually a loss. It's too much work to bill for it. So we don't bill those behavioral health services, and no one does. So we only bill for evaluations.
Is that under EPSDT that they're billing for that?
Nope, it's just a regular called out code.
Can you send me that code? Do you mind? Like putting it
Yeah,
in the
I
chat
can-
if you find it? Thank you very much.
Any other comments, questions, discussions, and we'll let Scott and Kevin get back to the presentation.
Great questions.
Yeah, and this is obviously what we want, so that you can see where you have commonality and where you have differences, and where might you perhaps meet if possible. Kate has some more questions, but she's going to wait until the end.
Okay.
So I'm going to give it back to Scott and Kevin. Thank you.
Thank you. No, I just to reiterate, I mean, that is exactly what we want it to be. So Kate, please feel free. I mean, you know, our slides are a discussion point to hopefully engage the conversation just like it did. So again, it's not like we're here to get through a slide deck. We want this to be an interactive conversation just like it has been. So so again, either feel free to jump off of mute or post those questions in the chat. And as you're thinking about them, some of the other things to highlight just about Michigan, Marjorie talked about in the very beginning about how I believe each of us on this call are BHWorks users, or at least have some relationship with BHWorks where they're looking to start using it as a care platform. The reason we selected it in Michigan is when I first took this position, it was right after that. So I talked about the State School Aid Act funding. And again, it was the first time in Michigan that we extended services to students without an individualized educational program or an individualized family service plan. So if you had an IEP or an IFSP, and that included social work services, those were the students in Michigan that were the only ones that were benefiting. When we expanded our Medicaid plan to include our other additional students, to be eligible for those services, as you can imagine, a lot of questions came forward. I was fortunate to get a position at the Department of Education to provide that technical assistance and be a consultant for intermediate school districts that were figuring this thing out. And first thing I did was just did a lot of listening. You know, what are the questions being asked? What is something that we can consistently do to get the intent of the legislation, which is for the adults and the providers to be directly providing services to students. That's what this was about. It was one thing to get the funding out, but then to actually see the funding start bearing the fruit and having providers work directly with students. It took a long time to get us there because again, there were a lot of questions. You know, does this mean I can only see students that are Medicaid eligible? Questions like, and these are great questions. And the answer is no. In Michigan, they can see all students. It just so happens if the student is Medicaid eligible, we can get a reimbursement for that service. And as Kevin talked about, we're not talking a dollar for dollar reimbursement, but we are talking a pretty significant percentage to be able to sustain the program. So as I mentioned, a lot of questions were coming up. What type of students can we see? How do we keep track of students that we're seeing? How do we measure progress? How do we report back to the state, you know, the number of students that we're seeing? And then what types of data does the state want to see? Do you only want to know students that actually have a plan of care? Do you want to know when we're doing crisis intervention, brief interventions, crisis management, and things like that? So we were fortunate to start doing our homework and came across mdlogix and their platform BHWorks, along with some others. And we had a lot of conversations with different vendors, but BHWorks really came to the top of our choices pretty quickly for a lot of reasons, not just because their platform itself being so efficient and user-friendly, but because things like this, the fact that we have a multi-state collaborative. Marjorie talked about the behavioral health learning collaborative. These are things that mdlogix, again, wasn't part of our contractual agreement with them to provide, but they're innovators. They're looking at the system as a whole across the country and bringing us in Alaska and Minnesota and Ohio and Nevada and other states together in a collaborative opportunity and format, which again, nobody else was willing to do that. And so we're very fortunate And what we've been able to do with BH Works is streamline a lot of those best practices. Give our providers time back to be able to actually work with students is so critical, especially considering all of us across the country are facing a shortage of professionals. That's no different in Michigan. So if we can save 5, 10, 15 or more % of a professional's time to track down things like electronic consents, or excuse me, to track down consents by doing things electronically and more efficiently, by getting students connected to services, because all in one platform, they can get those electronic consents. They can screen the child. They can take those screening results and then do a more informal assessment with that child. They can create a plan of care. They can track the goals and the progress of how that student is doing. All of that, like I said, takes place within that platform. Now, Michigan is a local control state. So if we were to ask all schools in Michigan to participate, we would not only have to pay for the platform itself, but we would also have to pay for all the administration costs and things to make that happen. It's one thing to say, here you go, intermediate school district, local district, here's this platform, go use it. They've got to, again, have all the administration costs. They've got to have somebody provide oversight, direction for that. So I'd love to tell you that 100% of Michigan is on board. It's not the case yet. We're getting close. We're at about 70%, 38 of our 56 ISDs. And we hope to continue to expand that with additional funding from the state so that we can look at more providers having more access to it. Marjorie, looks like you had another question for us.
Yeah, actually, Charles found a workaround the Zoom lockdown on the slides. So in the chat, he put a Google Drive link. And if you request access, then he will send you the link to the slide deck. So at least everyone can have that in front of them. And thank you, Charles.
One thing that I'm going to say is when we first started getting these funds from our legislature, I told people, I said, I see it as a 3-step process. The first step is to get these funds out to the ISDs and get our clinicians hired. Okay, check, we got that done. The second step is when those providers, or the second phase is when those providers start seeing additional students and they really increase the services. Then the third and final step is when we start seeing that needle on student mental health start to move. And that is where I see as BH Works being the biggest asset there. Not only on getting that needle moving better, but also being able to show us how that needle's moving on student mental health. So that is really where I think that we're in that phase right now. We're actually starting, I believe, starting to see the needle move, if you will, on student mental health in Michigan, but it takes time. And so the sooner we can get going, the better.
Hey, Kevin and Scott, I have a quick question about that funding. And I think I've asked you before, so if you told me, I'm really sorry. But do you know where it came from in a state budget? Sometimes we get opportunities to propose ideas based on a marijuana tax or a tobacco tax. But, you know, I've looked at the state budget for this biennium and there is not wiggle room. We also have another governor, but for the next biennium to propose projects, I just want to know, do you know where that initial startup funding came from within your state budget?
Kevin, you want me to take that one or you got a bunch?
Yeah, you go ahead and take that one.
So that, remember how I talked about, we've kind of seen a progression of increasing funds, Dana. So that first $30 million, that was actually set aside by the state of Michigan in their general fund budget. I mentioned that the funding has significantly increased. A lot of that has to do with those ARP and ESSER funds as a result of COVID relief dollars. So I do think that we will probably start to either plateau or get back to a smaller line item than what we saw this year, for example. But we were very fortunate that, again, it started with legislators having conversations around hardening of schools, and they were looking at investments in things like reinforcing entrances into schools, so like buzzer systems and things like that. They were looking at bulletproof glass, in those types of investments. And then kind of at the 11th hour, they kind of switched gears and then said, you know what, we really need to focus on why students are hurting themselves and each other. So we were fortunate that they set aside from the general fund an initial amount of $30 million. And then again, as we've been talking about, they made sure that they had something sustainable with that Medicaid expansion. We've definitely seen a growth. Like I said, I think this year we went from 30 million in the first year to, I think it's, I mentioned over $350 million total. Only 75 of that is actually recurring funds that we're going to be expecting to see. Most of that, unfortunately, will probably go away when those COVID federal relief dollars go. Kevin, what would you add to that?
You know, one thing that people are going to say is you can't use federal money to go after your after Medicaid reimbursement. But what that federal fund does is those federal funds allow you to use them in other areas that frees up state dollars to pursue the Medicaid match then. So that's the thing, is it's always being strategic about how you're using your money. You want to use your federal funds in ways that cannot be matched or cannot be used to seek additional funds, and then kick the state funds over to where they can generate some additional federal funds.
So can I call on Minnesota, Tom and Stephanie? So did Minnesota, you expanded your Medicaid, correct? And if so, how similar is this to Michigan, or is it vastly different?
Yeah, we expanded, beyond individualized family service plans and individualized education programs services to extend the same services to students who may have disabilities and it's not listed in their IEP or do not have disabilities. We have a very, we have a lot of challenges in the behavioral health domain for Medicaid billing by schools and reimbursements to schools. We have we've grown a very unique program and structured it with state statutes with the best of intentions, and unfortunately state statutes are pretty difficult to change. So as much as we're going great with special ed, physical therapy, occupational therapy, speech happening in our reimbursements, behavioral health reimbursements to schools. So we've looked at Michigan as an example. We've been doing a lot of communication back and forth with each other because they really demonstrate the possibilities. And some of us are working to just use the great work in Michigan as an example of what is possible. And it's not like it's even that far out. But sometimes, like I said, unique state programs grow and they get kind of rooted in statute. It's difficult to change things.
Mm-hmm. What about, thank you, Tom. What about Arizona? I know we have a few people in Arizona, and I'm going to go to the slide deck just to see where you are. Are you waiting to expand, or you're in the process of expanding? Or don't know yet, not sure.
Hey, this is Kyle from Arizona.
Hi, Kyle.
Hey, so I am not the foremost expert. I believe Kevin has been connected with Lisa DeWitt and Melina Solomon, who are our foremost experts. But we have expanded quite a bit, and many of these services that have been talked about are reimbursable. I don't want to speak out of turn, so I'm going to kind of leave it about there. But
that's fine.
Yeah,
that's
we have
fine,
expanded, and we are moving towards some really good things. And Kevin has actually been a big help to us previously, so thank you.
Yeah. I will reiterate what I said at the beginning is, if you're not sure where to start, Kevin probably knows his counterpart in your state to try to connect you. He's not only, as I said, a leader within Michigan, but also at the national level. And then Nevada, I know you guys, Dana and Tanya and a few others from Nevada, you're working on it though, obviously. How long have you been working on it and how's it going?
Well, a long time, but I think it was approved, the SPA was approved in 2019, and I wasn't part of that, but the actual implementation, there are 9 districts out of 16 or 17 that have their contracts. So we're fee for service state. But no one has billed for behavioral health yet. And so I think they're a little bit nervous. We think our statewide nurses on here that we're going to be able to bill for nursing most quickly. But they didn't have, and this is why we got invited to this call, there's no capacity to document across the state in any real way, in any private way. So we had to really start there and then expand. So get the technology and then expand the skills and the standards of practice for our school-based clinicians. And we have no money to do that. So we are doing it piecemeal with grant funding throughout the state, including ESSER and ARPA money. But, you know, hearing about the 30 million every time I feel jealous about it. Every time I try and figure out where to do it. So I feel really hopeful this year that we'll get there in little bits and pieces. But as a state, we're very much struggling with youth mental health. It's heartbreaking. So it feels like good work to do, but slow.
Yeah. So
Scott and I were in a meeting a few weeks ago, and the discussion went around the room where people were discussing how we had to use the $78 million and the problems encountered with doing. I said there are 49 other states that would love to have that problem right now. So quit complaining and make it work.
Yeah, we're rocking like 5 million and it's stringing it tight.
One thing that Scott always likes me to point out is that, you know, this hasn't been all join hands and sing kumbaya. You know, there has been some hurdles that we've come up against. And one of them is, as we pull people into the schools, we have to pull them from somewhere. And a lot of times we're pulling them from CMHs or other places, because for some people, the school schedules and things like that are more attractive. So when you're seeing things like that, you're building capacity in the schools, but as a state, we were not building capacity. So we started up some movements to ensure that we have a pipeline of behavioral health professionals coming in. So there are some problems that come up when you start really increasing the size of your program.
So
I think that's really critical. Sorry, Marjorie, just to piggyback on what Kevin said. I think that's such a critical point. And Dana, that's a couple of things that I'm thinking you could take back possibly to those people you're having conversations with. You know, one, obviously, you're in a prime time to take, I hate to say this, but take advantage of the current climate we're in, right? We're coming out of a pandemic. We've got national crises taking place with violence and things like that. So again, taking advantage of that, I don't like to use that term, but really that's kind of what you would be doing by going to your legislators. Second thing, to Kevin's point, if it has taken time, you can also be, while you're waiting for this funding, trying to work on, I know that I think it's Nevada State College has the Artery, which is a pipeline out there to look at behavioral health professionals, which is a phenomenal thing that we would love to beg, borrow, and steal from. So I think you're doing it exactly right, Dana, is what I'm getting at. You're getting the infrastructure there. Again, one of the things that you can be doing, taking advantage of that Artery, which is that talent pipeline, so that you got the professionals, so that you're not doing what Kevin just talked about, which we did in Michigan, steal from Peter to pay Paul. So I guess I just wanted to kind of reinforce that, yes, we're very fortunate that we have this significant investment from our legislators, but we also now are playing catch up in trying to figure out some of those unintended consequences that came with it, which you can be planning for and kind of working out as you're waiting for the other piece, which is that funding. So sorry, Marjorie, back to you.
No need to apologize. This is, again, the purpose of the collaborative is note those who are participating in this meeting. They are your colleagues. And as Scott just said, what he's been through, you could learn from them and hopefully make it a smoother way. And then also, you know, states who have similar challenges, maybe we can talk through ways in which we can get over that together. And so we only have about 4 minutes left. I'm only just going to give a reminder, and then I'll give Kate the last minute or so for a question from Alaska. A couple of things. I am going to send the slide deck. I know some of you have access from Google Drive now. I'll send the slide deck along with some resources. One unrelated to this topic, which is I found to be an interesting article by the National Academy of State Health Policymakers, talking about the workforce issues. And it did include a blog from Alaska about how they are addressing rural and frontier behavioral health. And so I'll send that link, and because that is something we are all struggling with, and nobody has like a concrete answer, but the state health policy folks obviously collect that information from the states, and maybe, you know, you can find a solution in that article. We will have a second quarter meeting in May, the date to be determined, but you will get the invitation. We are going to address how you use the data that you are collecting, mostly through BHWorks, and then how to use that information to expand your services, show your outcomes. And so that is an important component that you all wanted to address, and we'll do so in May. So Kate, we have like 2 minutes left, and thanks everyone for your understanding about the slide deck. But I do think it was a very productive hour, and I thank Scott and Kevin once again for sharing their experiences. Go ahead, Kate.
Thank you so much. My question is, I think I heard you guys say that there was a bill in 2018 that initially required your state to open up the state plan. What was that bill number? I'd love to just copy and paste that.
I personally don't know, and I won't refer to the language I used to describe it, but you know, because it pretty much robbed us of a Christmas that year. So my words for it were less than flattering, I think. But I think Scott's folks can come up with the exact the legislative numbers and things like that for you.
So Kate, are you looking for the $30 million that was set aside, or the way I interpreted your question was more like a bill that has said that we had to open up our state plan amendment? What were you, tell me more of what you're looking for.
I was looking more for what required your state to open up the state plan. Our state is very hesitant, but our legislature is trying to find innovative ways to better support schools. We've had a DOJ investigation of our state behavioral health system. We had a DOJ investigation on our school system. Basically, all child serving systems in Alaska are in crisis. And we lead the nation in youth suicide. So we need the state to open up the plan.
Kevin, to my knowledge, I don't think it was a requirement that Michigan opened up their state plan. Am I correct?
The legislative on the lame duck session, their final piece of legislation said that we would open up the state plan.
Okay, so there might be something all right, I will do my best to track that down. Okay.
One thing I will say is, you know, we're all reluctant to open up our state plans. You know, we all fear what CMS is going to come in and require of us when we do that. However, you can't operate without opening up your state plan and being that fearful of it. My experience with CMS is that they are willing to work with you. They are looking for the best solution. There have been decisions I didn't like from them, but I've actually agreed with them because they were right, and I was hoping they wouldn't be. But I think you have people at CMS that are legitimately trying to help right now. And yes, they do have some ideas that they've backed off on a little bit about response times to RMTSs and things like that. So right now, it seems like they are willing to work with the states at this point and try to help out.
Thank you.
And on that note, I'll just say that Dana posted before she had to jump off that she's going to share the Nevada behavioral health workforce retention, recruitment, and training materials, if that can help any of you, in addition to what I mentioned with respect to the State Health Policy Academy. Again, thank you all for participating today. Again, perhaps we can invite someone from CMS to perhaps join us in the future and talk about some of the common issues we have with them. But next meeting will be in May, date to be determined, data collection, and how to use that information. Thank you so much. Have a great rest of your week, and we'll be in touch.
Thanks, Marjorie. Kate, don't forget, Kevin and I are here whenever you want. So if you want to do something like we did today, but just the three of us, we're 100% here for you. So, and Kevin wants to go to Alaska just as bad as I do. So there's that too.
Say, bring me too. I'll go.
Wonderful. Well, maybe wait until the summer because we had record snowfall this year.
Yeah.
We're
It
all
snowed in Vegas
really
yesterday.
buried.
Oh, I'll bet. But yeah, seriously, any of you that want to follow up, again, a small team, like we, I thought we made some great connections at the NAME conference, and I know it's hard to keep this up, but whenever any of you are ready, Tanya, Kate, we're there with you. So just let us know.
I just
great.
want to ask Kevin one thing. And I want to say it's so nice to see you two. So Kevin and
Great
Scott.
seeing
like, it
you
was
again too.
Absolutely awesome. So I just wanted to ask you guys one thing without you going, Kevin, can you send us your EPSDT stuff that you were doing? We're updating ours now, and we really want to kind of look at what Michigan has done and kind of follow like your same thing. So what is your chapter for EPSDT, or how does it fit with your schools? Because we want to match our billing codes with your codes and all of that good stuff.
Yeah, it's pretty bare bones, but what I can do is I can send you a link to the EPSDT section. I can send you a link to our bulletin that we put out. And if you want, I can also send you a copy of our implementation plan with CMS.
Yes, that would be awesome. Rosanna, what else do we need from Kevin while we have him here? She's my partner in crime, and I'm dragging her in because I noticed she's still here. Come on, get on screen so you can say hi. I don't think Kevin has met you yet, or Scott, and I want them to meet you. So yeah. I'm the face of the team, but this is the backbone right here. Rosanna.
Sorry, hold on.
On board. There she is. So this is Rosanna, and our other sidekick is Gladys. And we're really working hard right now on our EPSDT. And so if you guys have just a quick second, we could ask you a few questions. If you don't mind, we would love it.
Not at all. Okay. I will say that EPSDT policy, I do not handle that policy. It's my good friend Matt Hamilton that does, but we work closely together, obviously, because I've got schools and he has EPSDT. So
we have both.
Yeah,
we get schools and EPSDT, so we get to kind of run both of them. So go ahead, Rosanna. What else do we need to know from Kevin while we have him here?
Well, so I think our main question was related to EPSDT, especially the OPR, ordering, prescribing, and referring NPIs to start billing, for EPSDT services. But like, if you can give us the contact info for the other person who handles the EPSDT policy, that would be great.
Our billing agency is refusing to bill for our EPSDT because they say we don't have an OPR. And we're like, you don't have an OPR because it's EPSDT. What the heck? That makes no sense.
Yeah, so it should just be for like screening and assessments, before any issues are, the children have any issues. And then the other stuff, it's always the way the school psychologists were approved in Nevada. So when it was first approved, basically it's the same qualifications than any other schools, than any psychology in the community. So basically they're, in line with those qualifications. So we're trying to figure out a way for the school psychologists to be able to provide services, especially because, the lack of providers. And we understand it's going to require a state plan amendment. However, at the same time, we want to make sure that services they provide are, meeting the scope and need of the students. So
medical necessity.
Yeah. And that's something that, we have been working on for a while. And
What's your question for Kevin, though? How can he help us?
yeah,
Or
so
Scott?
actually, I'm not sure if Scott or Kevin will be able to answer that. So do school psychologists in Michigan, do they have the clinical piece to be able to provide those clinical services?
I am not 100% sure. I've got some folks in the school psych.
I have on my thing, I don't know if this helps or not, but I've been doing a lot of research on this. I have Michigan as certified by their Department of Ed under the supervision of a licensed provider. Is that correct?
To bill?
Yes.
No,
No, not correct. Okay.
they're certified through the Department of Ed and can bill independently.
But they're not, they're not. See, how are they doing that? We don't get it. Like, our mind is blown because CMS is telling us no. So Kevin, what was your magic? Like, what'd you do?
It just happened to, like I said, to be at the right time where they said, oh, they're just rehabilitative specialists and we can put them under there. And it was
Yeah,
like,
that's what they told us.
but nobody
QMHAs.
else seems to get the same latitude that we got. I didn't even have to send chocolates or anything to them.
You did something. I know you did. It's like, maybe edibles.
Yeah.
That's what you sent them.
Yeah.
They were like, yes, we'll approve it.
Maybe it was
I don't-
just they just got tired of my phone calls. I don't know. So do something.
I
So,
don't know
but
if it's helpful at all. I just threw in the chat a link to, so what we did is we took all of our different providers and broke out their scopes of practice, like who needs to be supervised and things like that. It's from our license and regulatory affairs. So it may or may not be anything worthwhile, but I don't know. To Rosanna, your question about, do they also have the clinical piece? I don't think so. And that's why I threw that in the chat. 'Cause I think our school psychologists are credentialed differently. So take a look at that, see if there's any help, and just let us know.
Okay,
You
yeah.
guys rock.
Do you mind sharing your email, Scott
Yeah,
and
absolutely.
Kevin? And then if we want to follow up, if we need to follow up
For
with any
Matt
of the
too.
information yeah.
Throw Matt in there. We really appreciate you guys hanging back. I know you're busy.
Yeah, thank you so much.
It's like 4:00 there and snowing. And Scott, you said you have no power?
No, we lost it last night about 9:30.
Oh, dear Lord.
So yeah, the ice has just been, it's crazy driving here. I mean, the tree branches that were down from all the weight and just seeing everything like just hovered down from all the mass of the ice is
Oh,
crazy.
scary.
So it is, it's wild.
Now you got to get
Yeah.
home. Kevin, you're
Right,
working from
right.
home today, so that's good.
I always work from home.
Lucky.
See, that's me.
Right.
I want to work from home always. Our new governor is like, everyone has to go back to the office. Everyone has to go back to the office. And there's not even enough office spaces for everybody. And then, so you see Rosanna in the office, and did they finally fix the heater?
Yes, they did
Oh.
this
Okay.
week. So
It's
we
22
had no
degrees
heat.
there, and she's in a brick building that hasn't been occupied in over 2-3 years with no heat.
Oh my
It's like-
goodness.
She's like
Yeah.
shivering. I'm like, oh no, go home. I wouldn't do it.
Right, right.
Yeah, but thank you so much. We have a lot of, stuff that we need to resolve. And like Dana was explaining, they have been working so much in the last few years trying to figure out a way for a billing and tracking system, but we just don't have the funding for it.
We probably
And,
wrong way.
we have to be creative, like you said, and
Right.
figure out a way. Right
You guys
now,
got a great team. I mean, it was an honor and a privilege, seriously, Tanya, when we got to meet with
Thank
you
you.
and learn everything you're doing, the stuff that
yeah.
I've learned from Dana. You guys have a kick-ass team, and whatever we can do to help you try to get closer to that finish line, we are 100% committed to. But yeah, it's a pleasure to work with you guys. Like I
Appreciate
said,
that,
it's
Scott.
Yeah.
I really think
Absolutely.
once we get the EHR in there, the schools will start billing. Like, it's just going to happen innately. It's just a matter of getting that EHR. So as we're working, hopefully we get our Compass grant and we can get it from that, plus other grants that we're working on. So yeah, we'll go from there. But you guys rock. Kevin,
See,
don't
what you
forget to
guys
send
need-
me that.
What you guys need to do to raise funds in Nevada is you need to increase the taxes on those businesses outside the back gate of Nellis.
Those are more up in Roundhouse, up on the northern part of the state. It's like, where those are located.
Well, I was just talking about the bars and things like that out the back gate.
Yeah, yeah, we'll work on that one for sure. That'd be awesome if we could. Kevin, don't forget to send me that EPSDT stuff. I really appreciate you
I
guys
sure will.
so much. Thank you, Rosanna, for letting me call you out and you coming on.
Oh, it's okay. Thank you.
Hates it when I
Okay.
do that to her. Talk to you
It's
guys
okay.
later. Thanks.
Take care, guys.
Thank you.
Have a
Have a
great
great
day, guys.
day.
Have a good
Good luck
weekend.
with
Bye.
that snow there.
Yeah.
Thank you.
Stay
Take
safe.
it.
Yes,
Bye.
stay safe.